Thanks, Ishwar, for the introduction, and I thank you all for giving me this opportunity to present today. And um, so I'm going to talk today on stroke imaging concepts and strategies. And it's a fairly very common topic, as Ishwar mentioned, and if there's a lot of change or a lot of change which has evolved over the past few years, and there's also a lot of subtle variations in how we manage stroke and what is their imaging protocol. So if you have any others, I know many of you all have a lot of expertise in stroke imaging, so you feel free to uh, throw in additional information you have and chip in because it's a very complicated topic, and I would very much value the input of everyone who is here today. So I have no disclosures, and uh, let's begin by so the objectives of this presentation are to define a stroke and what is the role of imaging in acute stroke and what are the treatment options. And we will conclude by reviewing the American Heart Association guidelines for stroke management. And we will only talk about acute stroke imaging in our talk or presentation today. So the definition of stroke, according to WHO, is rapidly developing clinical signs of focal disturbance or neurological symptoms, which lasts at least 24 hours or longer, and or if leads to death within 24 hours. And the cause of stroke is strictly defined as being from a vascular etiology. When I say that, for example, if someone has a subdural hematoma and presents with weakness, that's not classifiable as a stroke. So a stroke has to be due to a vascular disorder. And when we say vascular disorder, it could be from two major types of vascular disorders. One is an ischemic stroke where there's a thrombus or occlusion within a major cerebral vessel or even one of its branches. And ischemic strokes, as we know, constitute at least 70 to 80% of strokes. The remaining 20% make up a big category called hemorrhagic strokes. And hemorrhagic strokes are due to rupture of small branch vessels within the cerebral hemisphere, typically the lenticular striate arteries, which arise from the middle cerebral artery and anterior cerebral artery. So the management for acute ischemic stroke obviously is different from hemorrhagic stroke, and we will review them in the next few slides. So why do we image a patient with stroke? And imaging is very essential. And no patient is going to get admitted even when there is a suspicion of stroke without any form of imaging. So the first and foremost goal of imaging is to determine if actually there is a stroke and not alternative pathology. Because there are some alternative pathologies which can mimic stroke, and we do a non-contrast CT. Okay, so that's the first line imaging we do in patients who come with acute stroke. Now, a big reason why we do a non-contrast CT is to identify if the stroke is hemorrhagic or ischemic, because that makes the decision to give tissue plasminogen activity, which is also called TPA, on a patient. So if it's hemorrhagic, TPA is withheld. If ischemic, TPA is administered. The next goal of imaging is to image the patient's cerebral blood vessels. And this is what we call as large vessel occlusion. We really want to identify if there is large vessel occlusion. And to identify that, we typically do CT angiography. CT angiography has replaced catheter angiography for many decades. And with our multi-channel CT scanners, we can acquire CT channel angiography very quickly, and we can actually get sub-millimeter thin slices, and we can also do 3D reconstructions. Okay. The definition of large vessel is the vertebral, the basilar, and the P1 segments of the proximal cerebral arteries, and the internal carotid artery, and the M1 segment of the middle cerebral artery. So that's the definition of large vessels. The next goal of treatment is, once you've done a CT angiography, is in a patient who actually has large vessel occlusion, will he or she benefit from endovascular treatment, and which is EVT. And the way you establish that is based on CT angiography again, where you actually do look for collateral imaging on multi-phase CT angiography, CT perfusion, or a diffusion weighted sequence on MRI. Now, the timeline for giving IV TPA is 4.5 hours for anterior circulation stroke. So this is mainly for anterior circulation stroke. Sometimes they do extend it to 6 hours for IV TPA. In posterior circulation strokes, we give IV TPA up to 6 hours. Now, for endovascular treatment, the deadline for providing or doing endovascular treatment is 24 hours, but the earlier, the better. So let us just review the findings on a non-contrast head CT. The acute findings are actually not typically seen in the first 12 hours. Typically, when a patient comes in with stroke, code stroke, most of the code strokes we see are usually small thrombotic strokes. When I say thrombotic stroke, it's a small occlusion in a distal cortical branch or a small lenticular striate perforator branch. So those are the small strokes, and they usually come with an NIHSS score. And I'm sorry, I'm not actually talking about NIHSS scores and all that, but they come with a stroke score, a very low stroke score. They typically, they don't really have a high score. A higher score actually implies a more grave prognosis. And those patients who come with low NIHSS score, or they actually have a negative head CT. So small strokes are hardly seen on a head CT within the first 12 hours. Now, if you have a large vessel occlusion, you typically can see findings in the first 12 hours. And one sign we always talk about in teleresidence is the hyperdense vessel sign. And the hyperdense vessel sign is claimed to be seen in 25 to 30% of cases, which I doubt, because this is probably from a series which probably is coding a higher figure. But the hyperdense vessel sign, if truly present, as in this case where I'm actually comparing both middle cerebral arteries, the right middle cerebral artery is actually hyperdense and contains a thrombus. It essentially implies that there's a large area of involvement. The other sign I'm looking for on non-contrast CT is loss of gray-white differentiation, which is well seen on this study, where you actually can see that you have great
particular slide and start.
Yeah. Okay, so I think we left here at the aspects, right? Alberta's stroke program. So are you able to see my screen for the aspects?
Yes, yes, yes.
So the aspects is, it's actually for those places where they do not have automated perfusion imaging. The aspect score has come into relevance because it actually compares the degree of hypodensity of the involved cerebral cortex. It's mainly used for MCA territory strokes. So if you look on, this is a normal head CT, and if you notice, there is, we actually, at the level of the basal ganglia, we have 7 territories, which include the caudate nucleus, internal capsule, lentiform nucleus, and we have 3 zones of the middle cerebral artery at the level of the basal ganglia, and just one level above the basal ganglia, we have another 3 zones. So we have a total of 10 normal zones. And if there's a hypodensity involving any particular zone, we subtract 1 point. So the initial relevance is if the aspect score was more than 8, we had a great recovery with IV-TPA, while a score of less than 7 had poor outcome with IV-TPA and hemorrhagic transformation. However, the subsequent relevance is when you actually do a non-contrast CT, if the aspect score is greater than 6, And if you have and we don't have perfusion software, then endovascular treatment is indicated. For those patients who have an aspect score of less than 6, we typically don't do endovascular treatment. So the whole goal of endovascular treatment is to look at the area of the brain involved. The less amount of area of the brain involved, the more likely endovascular treatment would be a benefit. The greater the volume, endovascular treatment will not be of benefit. The advantage of the aspects in comparison to CT perfusion techniques is it's a rapid triaging. You can quickly do a non-con head CT, exclude hemorrhage, and look for the aspect score. A great aspect score means that the patient can go for endovascular treatment. Obviously, it has a very high disadvantage because it's not automated. It's based on inter-observer. It's based on error. It's prone to errors from inter-observer variations, and it has a limited ability assessment on smartphones or tablets. So the next slide is about CT angiography. So every patient with stroke will undergo CT angiography. So a CT angiography obviously is done with right now multi-channel, like multi-slice CTs, and it gives you 1 millimeter thin slices or even less. And the whole goal of CT angiography is to look for large vessel occlusion. For example, as we define large vessel occlusion in the anterior circulation, it's mainly occlusion within the internal carotid artery or the proximal middle cerebral artery. It identifies site of critical narrowing and collateral. You also want to identify collateral flow in patients with when you do an endovascular, when you actually do CT angiography. So intraarterial thrombolysis or mechanical thrombectomy is performed for occluded ICA and only M1 or the horizontal segment. Okay, so the definition of M1 is the horizontal segment of the middle cerebral artery. Once the middle cerebral artery takes a vertical course in the cilium fissure, that is the M2. And mechanical thrombectomy for M2 is kind of questionable. Some centers go even up to the M2, but many centers stop at the M1, which is the horizontal segment. But some centers even do M2 mechanical thrombectomy. So, and there are many centers which also do mechanical thrombectomy for basilar artery, although it's highly controversial. And still there are a lot of studies being performed whether mechanical thrombolysis can or endovascular treatment can be performed for basilar artery. So let's look at the role of multi-phase CT angiography. And I'll admit that we in our place do not do multi-phase CT angiography, but there are many places which do multi-phase CT angiography. It adds radiation slightly to the patient. And this is a patient who actually has a occluded or M1 segment of the left middle cerebral artery. And if you notice, these CT angiographic images were acquired in multiple phases. So these are 3 phases. This is the earliest phase. This is a slightly delayed phase, and this is probably nearly a venous phase. So if you notice that there is reduced cortical flow on the early phase, but as we progress our scan timing, you actually see increased flow within the MCA cortical distribution. And this is a good evidence of collateral circulation. It is actually very well established. It's very well established that patients who have great collateral circulation or optimal collateral circulation on CT angiography, those are the patients who actually do very well with endovascular treatment. If the patients do not actually have collateral circulation on CT angiography, those patients are typically not benefited from endovascular treatment. So let's talk a bit about CT perfusion. So CT perfusion, many places have the ability to do CT perfusion. So in our place, when patients actually have a code stroke, they get a head CT, a CT perfusion, and CT angiogram, all done within like 15 minutes. Obviously, the head CT is done first to exclude hemorrhage, because if there is hemorrhage, you will skip the CT perfusion, okay? So CT perfusion is done only if the head CT does demonstrate absence of hemorrhage. And there are many vendors which sell CT perfusion. The one which we have and the one which is most popular is the Rapid software. And it's very automated. this is what we actually look for. We look for cerebral blood flow map and Tmax maps, okay? Cerebral blood flow, which is less than 30% of baseline, that equates to infarction. And if you notice, there is 0 ml, there is no area of cerebral blood flow less than 30%. It's literally 0. So this patient is not having an infarct. Now, the Tmax, Tmax is time to maximum. And when I say time to maximum, it is the maximum amount of time, it's the time to attain the maximum density of iodine in the brain. So if that is delayed, that patient is having either ischemia or infarction. So remember, orbit will take Tmax more than 6 seconds, and that volume gives us the combined ischemia and infarct. Remember, it's the combined ischemia and infarct. So what we're typically looking for in ischemia is the mismatch. So what is ischemia? Ischemia is nothing but Tmax minus CBF. In this patient, since the patient has 0 ml or no CBF, the mismatch volume is actually 26 ml, which is the ischemic brain. So this patient is an excellent candidate for endovascular treatment because he has a mismatched volume. What we're really looking for is a significant difference between the Tmax greater than 6 seconds and the cerebral blood flow. And this patient actually had mechanical thrombectomy, and this was the MRI which was done after mechanical thrombectomy, and all he had was a residual diffusion abnormality, which is the infarct. So that is how we actually, those are the indices we use, or parametrics we use for CT perfusion. Now, there have been many studies on which actually recommend when we have to do a CT perfusion, okay? So typically, CT perfusion is only done when you have large vessel occlusion. So take that. So if a patient does not have large vessel occlusion on CT angiogram, you do not need to do CT perfusion. That's very well accepted, okay? So your algorithm should be to do a head CT, a CT angiogram, and if there is a large vessel occlusion on CT angiogram, then you would do CT perfusion. Now, many studies actually say that if the patient presents within 6 hours and the patient has large vessel occlusion, you will do mechanical thrombectomy regardless. You do not need to do a CT perfusion, but not all centers follow that. But based on these big trials, you do CT perfusion only in the 6 to 24-hour window. So if a patient actually comes in less than 6 hours and has an MCA occlusion, a proximal MCA occlusion, they go for mechanical thrombectomy without a CT perfusion. So what you're looking for when you do a CT perfusion, what are the endovascular treatment criteria? You have to have a core infarct volume of less than 70 ml, meaning if your infarct volume is 150 ml or more than 170 ml, then you would, even though there is a mismatched volume, you would not do mechanical thrombectomy. And the difference between the or the ischemic brain volume should be more than 15 ml, and that is essentially the difference between the Tmax and the cerebral blood flow. So this patient actually has a mismatched volume of 47 ml and a infarcted area of 8 ml. So based on these criteria, this patient will undergo mechanical thrombectomy. But remember that there are a lot of pitfalls in CT perfusion. We see them time and again. So these rely on vendor software, and they're not accurate. They're definitely not accurate. Okay. So this is another patient who seemed to have fulfilled the criteria. There's actually this patient actually had a mismatched volume of 38 ml, and he seemed to be an excellent candidate to get a CT perfusion, like a mechanical thrombectomy. But if you notice on the head CT done prior to the CT perfusion, there are areas of developing infarction in the left caudate head, but those areas are not shown to be abnormal in CT perfusion. And this isn't true. If there's a discrepancy with what you see on a head CT and a CT perfusion, always believe the head CT. That essentially means that there's some erroneous calculation happening on the CT perfusion. And this patient got an MR brain immediately, and we can actually see that this patient is developing an infarct in the left basal ganglia, which is actually not shown on CT perfusion. So whenever you read a CT perfusion, look at the head CT and make sure that there are whether there are corresponding areas of abnormal signal on head CT which are not being picked up on CT perfusion. If there are, that means your CT perfusion is actually miscalculating your final infarct volume. Even now, MRI remains the gold standard for infarct estimation. It's not CT perfusion. So I just wanted to share this example of a patient who actually comes with a cold stroke and has a nice area of ischemia in the right frontal lobe. The Tmax is the infarct in the ischemic volume is 28 ml. So great candidate for endovascular treatment. And this patient actually underwent mechanical thrombectomy. So after mechanical thrombectomy, we do a non-contrast. Obviously, every patient gets a non-contrast CT. You want to assess for the potential for hemorrhage after endovascular treatment. So remember that both IV thrombolysis and endovascular treatment both actually can cause subsequent hemorrhage in the brain, but the incidence is higher with mechanical thrombectomy. So mechanical thrombectomy has a more likelihood of intracranial hemorrhage afterwards than IV thrombolysis. And this patient, on a few hours after mechanical thrombectomy, shows some hyperdensity within the right basal ganglia and right insular cortex. And we don't know how much of this is hemorrhage and how much of this is actually contrast staining from mechanical thrombectomy, because during mechanical thrombectomy, we inject contrast in the affected middle cerebral artery. So we do what is called as dual energy CT. We do routinely dual energy CT after post-mechanical thrombolysis. And the goal of dual energy CT is to identify what is hemorrhage and what is contrast staining. So on this iodine subtraction map, the contrast staining is subtracted and all you see is this hyperdensity, which equates to hemorrhage. And this is an iodine map, and the iodine map actually shows what looked kind of faintly bright on a non-contrast CT as extremely bright. This is an iodine map which maps the iodine. And if you can actually wiggle your eyes, you will see that these areas of hemorrhage, which you see on the iodine subtraction map, are actually darker on the iodine map. So that's the benefit, one benefit of dual energy CT, and we employ it after mechanical thrombectomy, is to differentiate between contrast staining and hemorrhage. It is clinically of value because if a patient actually has contrast staining, we just actually go ahead with our routine management. We don't actually make a change in the patient's management. But if there is hemorrhage, then patients, depending on the size of the hemorrhage, anticoagulants and antiplatelets are temporarily stopped. So this is another patient. Now we'll actually talk a bit about hemorrhagic stroke right now. So this patient comes in with cold stroke. He's a 66-year-old male, and he actually has a left thalamic hemorrhage. So there is something interesting in this left thalamic hemorrhage. It's kind of heterogeneous. It has some hypodensity. Sometimes we call that a swirl sign. And we did a CT angiogram. So remember, the protocol for intracranial hemorrhage is to omit the CT perfusion. So we omit the CT perfusion when patients have intracranial hemorrhage, okay? Because we're not trying to do mechanical thrombectomy, and we also don't give IV thrombolysis. We do a CT angiogram for various reasons. One, to exclude any underlying vascular abnormality, and two, to see if there is active contrast extravasation. And if you notice, it's kind of very faint, but there is this tiny bit of nodular blush here, right in the eccentric lateral margin of the hemorrhage, and this is contrast extravasation. So these two signs of swirl sign and contrast extravasation are not actually good. They're bad signs. They essentially mean that this hemorrhage is still actively bleeding, and this hemorrhage will progress in size. And this was the hemorrhage just 2 hours later. So from 2 hours later, this hemorrhage is actually much more denser and much more larger in size. And in combination, the active contrast extravasation, which is called the spot sign, and the hypodense CT sign are both predictors of hemorrhage expansion. So these signs favor hematoma expansion. Now, many centers have actually done when you actually see these two signs, they have actually given factor 7 on procoagulant infusions, but that's have now been proven to have limited value in preventing hematoma expansion. So what is the etiology of hemorrhagic stroke? This is an elderly patient who actually has a hemorrhage in the left occipital lobe, and we did a SWMRI, which not only shows the hemorrhage, but other smaller hemorrhage at the gray-white matter junction. So obviously, the etiology for this is not hypertensive hemorrhage, unlike the previous case. This was amyloid angiopathy. So some common cause of hemorrhagic stroke are hypertension, which remains the most common cause of symptomatic hemorrhagic stroke. Amyloid angiopathy, very common in elderly patients. In younger patients who present with hemorrhagic stroke, the most common or some common causes are AV malformation and venous sinus thrombosis. So now let's jump into MRI and what is the role of MRI in patients who present with acute stroke. Typically, we do not do MRI in patients with acute stroke. Our imaging protocol is mainly non-contact CT, CT perfusion, and CT angiography. There are certain situations where you actually do an MRI in the first 24 hours or within even at the time of admission, and those are have a specific reason. So obviously we employ diffusion, and we know that diffusion changes occur immediately. They occur within 10 to 30 minutes of onset of symptoms. That has a high sensitivity and of 88 to 100% and a very higher specificity. Now, there's a lot of debate. What does diffusion restriction mean? Does it mean ischemia and infarct or just infarct? So I have seen examples, and there are many examples in literature where people have actually had a diffusion abnormality, they've had thrombolysis, and the diffusion abnormality has reversed, and that makes people believe that diffusion abnormalities can imply ischemia also, reversible ischemia, but those are very few examples. On the whole, most diffusion restriction, essential diffusion restriction implies irreversible infarct. So remember, it's an irreversible infarct. You're not actually going to save that brain tissue. That brain tissue is actually dead. So diffusion, as we discussed, is positive in 1 to 3 hours. A flare is slightly better. It's positive by 6 hours. And T2 images are usually positive by 12 hours. So that's our original sequence. T1 is very insensitive. It takes up to 24 hours for any T1 signal changes to develop. So obviously our diffusion and flare are the earliest sequences which are positive in patients with stroke. There is something called diffusion flare mismatch, and it's very important to recognize that. And that's the whole utility of MRI in the acute setting. So this is a patient who actually had a right basal ganglionic stroke a few weeks ago, and that's the diffusion and the flare. A few weeks ago, he had a right basal ganglionic stroke, was admitted, and then he was in altered mental status and lethargic, and they didn't know what was going on. And they immediately brought him down for an MRI. And you see this new infarct developing in the left basal ganglia and left parietal cortex, which kind of is faintly seen on flare, but not that impressive. So this is the best example I could get for a diffusion flare mismatch. Essentially, a diffusion flare mismatch on an MRI in the acute setting means that this infarct is less than 6 hours old, because as we discussed, flare takes approximately 6 hours to develop. And these patients who have a diffusion flare mismatch are in the time window for effective thrombolysis. Okay, so when do we use that? And we'll review that in the next slide. So what is the status of MRI in the acute setting? So if you're planning to do MRI in the acute setting, remember, do not do a full protocol MRI. Do not do the MRI angiogram. Do not try to do post-contrast. Do a very limited MRI, which you can finish in less than 10 minutes. So our limited MRI protocol in the acute setting to triage patients with stroke, and this is when I say acute setting for 6-7 hours, is to do a limited DWI, SWI, and flare. Only 3 sequences, doesn't take more than 10 minutes. And when do we do it? When the the neurology team is not convinced that this patient actually has a stroke, and they want to withhold IVTPA for various reasons. And and they want to only give IVTP if this patient has an established diagnosis of stroke. So they're not sure. So they really want to do an MRI to make sure that there's a diffusion abnormality. And there is something called wake-up trial. So let's say a patient wakes up with a stroke and they actually don't know how long their symptoms have been. They don't know if they've actually had the symptoms for 6 hours or more. So then, since you cannot rely on the patient's history, you actually do an MRI and you acquire a diffusion of flare. And if there is a diffusion of flare mismatch, that essentially means that the infarct is less than 6 hours and you give IV TPA. Now, in certain situations or certain institutes which actually do not really believe the perfusion software's capabilities, and if they contemplate on doing large endovascular treatment, they will do a diffusion MRI and they will have volumetric software or software which calculates the volume. And the diffusion volume is greater than 100 ml, then the endovascular treatment is not performed. So these are some main reasons why you would do MRI in the acute setting. We typically do not do MRI in the acute setting unless there's a reason, like as in these cases. Our typical MRI is done after 24 hours. We do MRI after 24 hours after stroke symptoms. You do have to remember that not all cases are positive on diffusion. There are many cases which can be negative on diffusion. And what is the reason? This is an example of a 48-year-old male who had right side weakness and numbness. CT angiography is normal, diffusion is normal, everything was normal. So one common reason why the diffusion negative is TIA. So in transient ischemic attack, the definition of transient ischemic attack is symptoms which resolve within 24 hours. And these patients actually do not have a true infarct. They only have ischemia. And as we all know, ischemia is not shown on DWI. So whatever is shown on DWI is infarct. So ischemia looks normal on DWI. So these patients may have had a TIA. That's the reason why the diffusion is negative. Sometimes it may be the patient, they may not have had a stroke. The patient could have had some epilepsy or seizure or migraine. And that's the reason why the diffusion is negative. Tiny strokes, very, very tiny strokes are beyond the capability of diffusion. And even those are negative on diffusion. Hemorrhagic transformation is very, very common after stroke, and we see it very common in large vessel strokes. And it's and that's the reason why in patients with large vessel strokes, we frequently do CTs after treatment while they're admitted, and they undergo an MRI also while they're admitted. And we look for hemorrhage, and as we know, this is we arbitrarily divide hemorrhagic transformation to hemorrhagic conversion of infarct, where the infarct partly undergoes hemorrhage versus a parenchymal hematoma where the entire infarct undergoes hemorrhage. Now, I feel the distinction is slightly arbitrary over here, but what you really want to know is that hemorrhagic transformation begins on the 3rd day. And patients with large vessel occlusion, a low aspect score, those are the patients who actually are more likely to develop a parenchymal hematoma or hemorrhagic transformation. And you have to remember that not all patients with hemorrhagic transformation will need cessation of anticoagulant. It depends on the extent of the hemorrhage. In patients with parenchymal hematoma, where the entire infarct is occupied by the hemorrhage, those patients probably will have anticoagulation suspended or arbitrarily stopped or temporarily stopped for a few days. But for those with simple hemorrhagic conversion of few areas, those patients may still undergo or still continue to have thrombolytic medications. And lastly, not all patients with stroke actually have a stroke. So this is one patient who I saw many, many years ago. Maybe it's been 12 years since I've seen this patient. He came to the ER with right-sided weakness, and we saw this big ill-defined mass with vasogenic edema, and we immediately got an MRI, and he had actually had a GBM. So sometimes patients actually have subdural hematomas. Sometimes patients actually have MS. We've seen young patients come with acute right-side weakness, and they have what looks like MS sometimes, and sometimes they have brain tumors. So not all patients with strokes who clinically present as strokes actually have a stroke. So they may have alternative diagnosis, and sometimes these alternative diagnoses are not picked up on CT, and we give those patients IV TPA. So what is the imaging recommendation and management of acute ischemic stroke prior to 6 hours? And these are guidelines from the American Heart Association. Everyone receives a non-contrast head CT prior to IV-TPA administration, and IV-TPA administration is given up to 4.5 hours after treatment, after symptom onset, and is given prior to performing a CT angiogram. Every patient gets a CT angiogram, and regardless of symptoms scale, and that is to assess for large vessel occlusion. And if patients have large vessel occlusion and they present before 6 hours, they undergo endovascular treatment, okay? And no requirement for perfusion imaging or MRI if they have large vessel occlusion and symptom onset below 6 hours. What is the eligibility of endovascular treatment beyond 6 hours? So remember, after 6 hours, no one gets IV-TPA, no one. So IV-TPA, 4.5 hours, maximum 6 hours. After 6 hours, the only treatment you can give for patient with stroke is endovascular treatment, which is, again, mechanical thrombectomy, clot removal. So based on these two trials, you do a CT perfusion and you calculate the amount of ischemic brain or the mismatch. And if there is a significant amount of mismatch, you perform endovascular treatment. Or alternatively, if you do not do CT perfusion, you acquire a DWI MR brain, and if the volume is less than 100 ml on DWI, you go ahead and do endovascular treatment. For posterior circulation stroke, we typically only do IV TPA. There are far few centers who actually do endovascular treatment for posterior circulation stroke. And the reason is studies have so far not shown a great benefit of endovascular treatment for posterior circulation stroke as opposed to anterior circulation stroke. So that's all I have, and I'm really extremely sorry for all the technical glitches. I think what happened, Ishwar, is I entered Zoom on I went to my internet browser, I went into Zoom. Actually, Zoom was downloaded on my desktop. I should have just used the Zoom icon, but instead I went on to and entered the meeting from Google Chrome, which I should not have done. I learned my lesson, sorry.
Not an issue. Thank you. That was comprehensive. We have some neurologists as well in the audience. The way it's practiced here, it's more of MR than CT and CT perfusion, though the guidelines and the books still say that non-contrast CT is the first mode of presentation. But we end up doing more MRs and identifying most of the bleeds on an MR than on a CT. Some of the practice areas from the neurologist is slightly different from the recommendation. Any comments from the neurologists and other seniors who practice stroke imaging? Welcome. Dr. Bhavani, you have something to add?
No, sir. Thank you. No, sir. We usually do more of MRs than CT, as you said.
Yeah. One question, Siddarth, is about SWI showing microbleeds or small bleeds in the infarct. Is it, what is its significance, its role in deciding about anticoagulation and IV TPA? How do you go about it if by chance you do an MR in addition to the CT as well?
Oh, sure, absolutely. So that's a rare scenario because typically we don't wait to give IV TPA by the time we do MRI. But if you actually do, and as we said, because there was this scenario where we're not sure if there's a stroke, and we do our limited protocol of DWI flare and SWI. So if the SWI shows microbleeds in the infarct, we still go ahead and give IV TPA. The presence of microbleeds is never, ever a contraindication to give IV TPA. Now, if the entire infarct appears hemorrhagic, then we do not give IV TPA. But no, microbleeds within the infarct, and even in patients with, let's say the patient actually has amyloid angiopathy and there are some other microbleeds elsewhere in the brain, not at the site of the infarct, we still go ahead and give IV TPA. So microbleeds are never a concern for us.
Yeah, we do have a dual energy single source scanner, and this particular iodine stain versus hemorrhage after mechanical thrombectomy was told to us by the vendors. We haven't still used that, but I think that looks a promising add-on from a dual energy CT.
Yeah, it's so there are a couple of options like yeah, if you they say that if you actually have a dilemma whether it's iodine staining or hemorrhage, you can reimage after 24 hours, but 24 hours is a long gap. If you're trying to stop anticoagulants, people get nervous waiting for 12 hours or 24 hours because typically iodine staining resolves within 24 hours, whereas hemorrhage persists. Yeah, so dual energy is a absolutely wonderful tool because we actually have what is called as an iodine maps, and those iodine maps quickly subtract the hemorrhage and just show the contrast staining, and it's all automated, and it does not actually increase the radiation dose, obviously, but if someone is concerned about radiation dose, but yeah, I think it's we do it routinely in patients. We don't do routinely dual energy. One of our reasons for dual energy is post-thrombectomy, post-mechanical thrombectomy patients.
Do you do it as a routine, or if the patient deteriorates after thrombectomy? The dual
No, we do it as a routine after post-thrombectomy.
How many hours after?
So, so that's variable. Typically, after post-mechanical thrombectomy, I've never asked my neurologist, but I've seen them get it by 6 hours. By 6 hours after post-mechanical thrombectomy, and these patients after mechanical thrombectomy, they sometimes get. I've seen them get serial head CTs they get a head CT every day while they're in admission. They get a head CT every day. And if they have a large hemorrhage, they probably would get it more frequently. But yeah, typically starts at 6 hours.
Yeah. What do you think is the role of ASL imaging and perfusion and diffusion? Like, what do you think its role would be? Vis-a-vis the contrast perfusion, what we were doing before, and on MR.
So we are not using ASL perfusion. Our role, though, since when we do ASL perfusion, the only reason why we do ASL perfusion is in seizure imaging. That is, we are limiting our ASL perfusion. We are not using ASL perfusion. At least we don't have any experience in ASL perfusion imaging for stroke. And for example, actually, we've discarded MR perfusion completely for stroke. Like when I started my fellowship, we did a lot of MR perfusion, less CT perfusion, but the calculation of all these determinants like penumbra, mismatch, and infarct volume have been better. They have shown better promises with CT perfusion rather than MR perfusion. So in general, MR perfusion is now lagging behind CT perfusion in stroke imaging. So our ASL imaging, we typically are doing it in epilepsy patients right now to identify their epileptic source.
How do you go about in patients with borderline renal function or mild early CKDs where contrast administration is of concern in CT perfusion, CT angiogram? Yeah. Do you go in for MR in that situation?
So it's this is like a major guidelines about role of. So in our place, in many places, we are trying to move into this whole concept that in patients who have an acute medical emergency, it doesn't you suspect a PE or a stroke, like PE stroke, or you suspect aortic dissection, acute chest pain. So in those patients, we always assess risk benefit, and in those patients actually get contrast regardless of kidney function, because we're trying to do life-saving diagnostic measures over there. So what we typically do is we go ahead and do the text. You do call us saying, has this patient actually has low GFR, and they get our approval. And in even those patients with renal failure, we still do CT perfusion, CT angiogram, and not an MRI. And we just do IV hydration we just maintain the patient in IV hydration. So for acute neurological and cardiac and emergencies, we do CT angiograms and CT studies and just hydrate the patient. We do not go for an alternative MRI.
Yeah, I think I wanted
So
to
are you,
guidelines.
also, what is the practice in India? You, in those situations, do you do withhold the CT and do an MRA? Is that the practice?
As I've already said, and my neurologist colleague also says, it's mostly an MR which is done here for acute stroke, especially ischemic stroke. But we end up doing MR even for hemorrhagic stroke as well. We pick up thalamic bleeds, we pick up interventricular hemorrhage, even if we pick up subarachnoid hemorrhage on an MR, we find SWA is really good in picking up. But the CT perfusion hasn't really caught on here for various reasons. Yeah, but I understand MR is sometimes challenging in an acute stroke situation, patients not cooperating and restless and all that stuff. Whereas CT would be much easier and simpler. Yeah. Any other comments from Dr. Jagan or Jayalata? Any others have something to add? I understand these are predominantly for thrombotic or embolic situations, what you have mentioned. Are there any other indications, say something like infarcts after an infection, say suppose meningitis? Are they also treated with therapies you have mentioned? Or a mycotic?
You're talking about
vasospasm after subarachnoid hemorrhage and meningitis and endarteritis, vasculitis.
Yeah, now typically for those patients, like the very common example you bring about is vasospasm, because that's a very common cause of stroke. Subarachnoid hemorrhage actually is a common cause of stroke. So if I'm specifically about subarachnoid hemorrhage, no, we actually give the patients calcium channel blockers. And sometimes they actually do intra-arterial infusion of calcium channel blockers also to prevent the vasospasm, but mostly it's systemic calcium channel blockers. So yeah, so the treatment for vasospasm from subarachnoid hemorrhage is either intravenous or intra-arterial calcium channel blockers. And I'm not really sure about meningitis. I know patients with meningitis can get stroke. I'm not specifically sure about how they manage. I think they get, I know they do not get endovascular treatment for sure, because there is no thrombus in the vessels. It's occlusion from the meningeal infiltrate. So I'm sure there is no endovascular treatment, because the problem is not within the vessel, it's outside the vessel. But the stroke, the biggest stroke category we see is among the categories you mentioned is vasospasm from subarachnoid hemorrhage, and they usually get systemic intravenous vasodilation.
Yeah. You said about the swirl sign and the spot sign and ongoing bleed in an acute parenchymal hematomas. Is there any? Do you see any role for endovascular occlusion of those arteries and embolization to prevent further bleeds? Is there any?
Yeah, so the problem with endovascular occlusion of those arteries is typically it's not a it's a very serious issue trying to endovascularly embolize the intracranial arteries, because what happens is when you actually have an intracranial hemorrhage, it's one of the perforators of the MCA, which is one of the very tiny distal perforators of the MCA, which is actually undergoing extravasation. And no neurosurgeon or no endovascular neurosurgeon can go and reach that tiny vessel over there. So typically when you have say a retroperitoneal bleed, or when you actually have a neck bleed, you actually try to embolize a proximal vessel. So you occlude a proximal vessel. But the problem in the brain is if you exclude a proximal vessel, you're going to infarct a whole area of the brain. So that's the reason why no one does embolization for intracranial bleeds. They do embolization for subdural hematomas and epidural hematomas, because that's the external carotid artery branch, that's the middle meningeal artery. But for intracranial bleeds, no one typically does it, because there's a large, they do it for AVMs, but not for stroke.
Yeah, sure. Yeah, the risk of stroke, I think, ischemic stroke is much, much larger than trying to prevent a bleed there.
Because if you embolize the middle, if you occlude the middle cerebral artery supplying those perforators, now you're going to cause a big middle cerebral artery stroke.
Yeah, true. Anything specific for pediatric strokes? Do you have any other guidelines or something else for that category? Or the guidelines will be the same?
Great question. So, Ishwar, you brought this up very well because I am not aware. So for pediatric strokes, obviously the etiology for pediatric strokes is obviously much different. But there are a lot of, especially we see there is a lot of patients who actually have stroke. So I'm not sure if, and I have to read about it, and that's probably my homework right now, is when in endovascular treatment, do they offer in pediatric people? I do not know. If anyone can comment, do we actually do mechanical thrombectomy in pediatric patients? I do not know. I do not know the guidelines for children. Does anyone have any idea?
Yeah, maybe I don't know if there's any endocarditis or something which has an embolus. I don't know.
So the etiology of pediatric stroke is actually there's a different etiology. So most of the patients who actually in children who actually have a congenital heart disease. Congenital heart disease remains one of the most common cause of a pediatric stroke. And as we become a bit more older in the teenagers, sickle cell, especially sickle cell, is very common here. So sickle cell and is another common cause of stroke over here. So we see a lot of cases of moya from sickle cell, which presents with stroke, and dissections. In younger adults, we see a lot of dissections. And the treatment for dissections, in general, the treatment for dissections is to give antiplatelets. Now, if the dissection involves the intracranial internal carotid artery, then they actually undergo stenting. So typically, it all depends on where the dissection is. If the dissection is extracranial, they do antiplatelet treatment. If the dissection is intracranial, they undergo typically stenting. So that's the treatment for dissection. But the concept of pediatric stroke is obviously very broad, and I don't know the specific guidelines in terms of endovascular treatment when they have thrombotic or embolic occlusions.
Yeah, thank you. Dr. Navya, have anything to add from Singapore? She practices in Singapore, neurology. What do you say, Navya, about your practices over there?
Hi, sir. We actually do everything except CT perfusion here. And stroke, we only use it for the wake-up stroke. MRI, we use it only for the wake-up stroke. Ideally, as soon as the patient comes, we do the CTA, but CT brain and CTA, but not MRI. Unless it is a wake-up stroke, we don't know the time of onset.
Oh, thank you, Navya. I think you're following the AHA guidelines.
And I also wanted to say, as Siddarth sir has told, basilar occlusion, they still go in, but I have seen post TVT also the imaging is bad. I mean, posterior circulation infarcts are very bad.
Yeah, thank you, Navya. For
Siddarth,
you said that for posterior basilar and vertebral occlusions, mechanical things are not as often done as for the anterior circulation. But I think here we have a more aggressive approach in India. A lot of people go in for basilar thrombosis. They tend to do mechanical thrombectomies. And then, of course, if there's a stenosis, they do stent them as well. And of course, the window period is also slightly larger than for the anterior circulation stroke. Yeah. Are there any more questions? Any comments? Yeah, thank you, Siddarth. Appreciate your time and summarizing it pretty lucidly, both the role of CT and MR. I think if somebody needs to follow the guidelines, yes, CT and CT perfusion would be the order of the day. And try to triage for IVTP versus mechanical thrombectomy versus prognostication in terms of volume infarcts. And a lot of people end up with decompressive cranectomies here as well. I think it must be the same for large infarcts in your clinical setting as well. So that also is a major concern. And going on to prolonged rehab programs, that's again, we could prognosticate and try to limit those events. That would be a definite goal for imaging and intervention. Thank you, Siddarth, for your presentation again from KREST in Hyderabad. I look forward to more advances and more interesting presentations from you down the line. Thank you so much.
Absolutely. Thank you, everybody. Thank you for all attending, and thank you again, Ishwar sir, for